This is EHJ Today at the European Society of Cardiology in London 2015. I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm talking to Otavio Berwanger from the Hospital de Coração in São Paulo. He's director of the Institute of Research there and will present the VISION study. Welcome.
Thanks very much, Professor Lüscher.
So, the VISION study, what is it about? What made you do it? Made you design it?
Well, first of all, thanks very much for the honorable invitation, and on behalf of Dr. Devereux, Chair of the Steering Committee, and all the study groups, I'm very pleased to be here. You know, preoperative cardiovascular events we consider to be a forgotten problem. We have a lot of good and sound evidence in acute coronary syndromes, heart failure, hypertension, dyslipidemia, but we don't know a lot about cardiovascular events occurring in the preoperative period. So we conducted a large 40,000 patient prospective cohort study involving 8 countries in all continents in 12 sites. Aiming to include a consecutive sample of patients. And we have several objectives, and one of the objectives was to really identify potential targets, potential interventions that are associated with lower cardiovascular events.
For eventually a large trial, I think.
Exactly. So we could really identify some signals and some targets that could be a matter of future large-scale trials.
So it's actually a prospective registry with the attempt to include every patient in a given center.
Exactly. We aim really to reduce and to control for selection bias to include a consecutive sample of all patients with age greater than 45 years, undergoing non-cardiac surgery, who had an overnight stay, really to just exclude very small surgeries.
So you wanted to restrict it to a bit elderly group?
Yes.
What was the reasoning behind it?
The reasoning was to be able to ascertain a certain number of events that will allow sufficient statistical power to test the associations.
And you had an independent events adjudication committee?
Exactly. So we have all events were adjudicated centrally, and we also proposed a new event called MINTS, which is myocardial injury after non-cardiac surgery. So it's more than infarction, and the first VISION publication showed clearly that patients who have elevated troponins after surgery have a much higher mortality, and probably that's one of the major predictors of mortality after non-cardiac surgery.
Right. Now, in the presentation today, at this meeting, you were focusing on statins, I understand. Yeah. Why are statins potentially important here? Well,
we have not a single established intervention that reduce perioperative cardiovascular events. And previous evidence, we have some small randomized trials, and 3 of these randomized trials were included in recent systematic reviews, but we have just 178 patients, suggesting that statins may be associated with lower events, myocardial infarction, and we have about 10 previous observational studies also showing significant effects of statins. Some people claim that statins may have other properties other than, of course, it's well established for long-term prevention of cardiovascular events, but it may be its pleiotropic effects, anti-inflammatory, endothelial dysfunction, antithrombotic, may be useful in the situation of a perioperative setting. So that's why we thought this is based on previous evidence, and since we have such a large database with prospective data, with control for selection bias, adjudication for events adjudication, we'll have the opportunity to test this intervention.
Yes. So how did you define then a statin user?
Yeah, this is always tricky in a large data set as opposed to a randomized trial, but we did the data we have, it's patients that use statins at least 7 days before surgery, and then we did a propensity score, or match it by a propensity score matching method to patients who did not use statins after surgery, but we also did a sensitivity analysis comparing patients who use statins before surgery and continue at least 3 days post-op. So we did both analyses which were consistent. But really the definition was very general because this is how much the data could give.
Some may have actually taken it for years and others just started.
Yes, yes. And we also had information and vision that patients who use it less than 24 hours before surgery, but there were very few so we could not really test this specific question in vision.
So what did you find?
So it was very interesting. So in this study, of course it's an observational study, so statins were associated with a 70% reduction of a composite endpoint of cardiovascular events, that is all-cause mortality or means or non-fatal stroke, was also associated with a lower all-cause mortality and individual endpoints of means, and also a signal towards lower myocardial infarction stroke, although myocardial infarction and stroke were not statistically significant. Cardiovascular mortality was also reduced, importantly, almost by 60% and almost a 40% reduction in all-cause mortality.
So these are enormous reductions, also compared to randomized trials, right?
Yeah, this is true for any observational studies. I wouldn't expect that the effects would be that large. No. Of course, we did robust propensity score matching methods and also attempted to control for confounding bias, but in an observational study also it's impossible to eliminate residual confounding. So for sure I would, in a randomized trial, would target for much lower events, probably in the range of 20%, 25%, or even less than that. In our primary endpoint, the combined endpoint, which the one we have more events, is almost 12% event rates at 30 days. So it's really high.
One in 8 had an event.
Sure.
That's quite high. Yeah, absolutely. Yeah. And what operations did you look at mainly?
Well, in vision we had the opportunity to include a broad range of surgeries, and that's also a difference between vision and previous observational studies. So we have orthopedic surgery, we have vascular surgery, general surgery, and also we were able to include even what we call low-risk surgeries. And so it's really a broad range from different countries. As I mentioned, we have 8 countries in vision from all continents. So it's really, would be I think a strength of the study. Was the first observational study to include such a broad range of surgery.
Was there any difference between the different surgeries in terms of event rate?
Yes. Of course, if you look, not specifically in this analysis, we did not test exactly that, but we know from vision that especially orthopedic surgery and vascular surgery patients are at a very increased risk of perioperative events as compared to, let's say, a low-risk surgery or other types of surgery. But in this study specifically, we conducted some subgroup analysis, and once again, we have a lot of limitations on doing a subgroup analysis in an observational study. But anyway, there was no difference between types of surgery and the surgery risk. The only subgroup actually
in terms of the effects of statins.
In terms of the effects of statins, yeah.
Exactly. And what about age? Was there an age-dependent increase in event rate?
Yes. In vision, elderly patients had substantially more events. In this specific analysis, there was also no age effects. I mean, no.
So the statins would work in any.
Exactly.
So, what is your conclusion, and what are your next steps then?
So we think that this observational study is hypothesis generating, and in order to really confirm these results, we will need a large-scale randomized trial. We recently conducted a study called LOAD, which is a pilot preoperative study in 600 patients in Brazil. Results should be available in a short period of time, but we also planning in using this preoperative network to do a large-scale statin trial that will be much needed in order to answer this question reliably.
And how many patients would you need?
I would say that a statin study will be very similar to POISE 1 or POISE 2 studies. We'll need at least, let's say, 10,000, more than 8,000 patients, ideally 10,000 patients, in order, considering this event rate of 10 to 12%, at 30 days in order to find like a 20 to 25% relative risk reduction, which will be moderate but plausible.
Right. Well, that's very interesting. Thank you very much indeed for sharing the results of the VISION trial. And for those who are interested in the effects of statin in perioperative care, this paper will be online in the European Heart Journal as we speak.
Thank you very much.
Thank you.